We're just beginning to learn about how VEGF elaboration from tumors may foster an immunosuppressive environment. In at least preclinical models, VEGF upregulates Tregs, it upregulates myeloid-derived suppressor cells, and also decreases T cell trafficking. So when there's VEGF around in the tumor, there's a good chance that the tumor in and of itself may be immunosuppressive and less likely to be recognized by the immune system, which is all the more rationale why we're looking at targeting VEGF with anti-angiogenic strategies with immunotherapy.
In metastatic non-small cell lung cancer, we know that tumors need to feed themselves. And they do this by producing certain pro-angiogenic factors like vascular endothelial growth factor, VEGF. So we do know that targeting this angiogenic pathway using antiangiogenic inhibitors can be beneficial for our patients. The antiangiogenic inhibitors have various different modalities, some of which are monoclonal antibodies, some of which are tyrosine kinase inhibitors. The monoclonal antibodies work by taking VEGF or serum VEGF out of circulation. So essentially it breaks that pathway's bond between the ligand and the receptor. And that's usually the way it works to inhibit angiogenesis.
Anti-angiogenic strategies have come a long way for lung cancer. We know that anti-angiogenic strategies, drugs that target VEGF ligand and the VEGF receptor, help reverse much of the dysregulation that occurs in tumor vasculature. When we target the VEGF by delivering these drugs, we're allowing drugs to better be delivered to the tumor. Those drugs may be chemotherapy and they may be immunotherapy, but it allows for reversal of the disruption of these vessels and allows for better drug delivery. The VEGF TKIs have been tested quite a bit in advanced non-small cell lung cancer. Several of these drugs, nintedanib, vandetanib, sunitinib, sorafenib, these are all oral therapies, and unfortunately, when these drugs have been evaluated, they've been looked at in combination with chemotherapy in an unselect patient population with advanced non-small cell lung cancer, also in the chemorefractory setting in combination with docetaxel and other drugs. These drugs, for better for worse, just haven't demonstrated meaningful improvements in overall survival. I think there was a lot of hope that these drugs would work. There was a lot of scientific rationale why they may work. While nintedanib does have an approval in Europe, based on a subset analysis in an adenocarcinoma patient population, it doesn't have an approval here, and none of the VEGF TKIs are currently approved for advanced non-small cell lung cancer.